Okay. Hello, everyone. Thank you for attending. Welcome to today's panel discussion, Charting the Path for Pediatric Research and the Patient Experience. I am Megan Carmelani, the founder and president of Long COVID Families. I'm honored that we're joined today by some of the leading researchers and advocates in pediatric long COVID. COVID-19 and long COVID are serious health issues affecting children. Nearly 6 million children and counting in the US alone have long COVID. Yet levels of awareness remain unacceptably low. Long COVID describes lasting effects of COVID-19 infection, including ongoing, relapsing, or new symptoms that show up after acute illness. These can be persistent symptoms that don't go away, and/or new health problems that show up after the initial recovery period. What's unique about pediatric long COVID and has been surprisingly hard to get across is that kids are not little adults. Their immune systems, bodies, and brains are in dynamic periods of development. As a result, long COVID can present differently in kids than adults and urgently needs to be understood. The latest research from the Recover Initiative, published 2 weeks ago in JAMA, documents that symptoms among kids can vary. Fatigue, headaches, difficulty concentrating, gut pain, and respiratory issues are common. As children head back to school this fall, the risk of COVID-19 and long COVID among kids goes up. Today, we'll dig into what we know about long COVID in children and what needs to happen next in research and in the patient experience. A Q&A session will allow participants to engage with the panelists. If you have any questions for the panelists, please put them in the chat, and a member of the Long COVID Families team will be monitoring and compiling your questions so we can address them during the Q&A. I'm very honored to be joined here by Dawna Ballard, Dr. Amy Proal, Dr. Megan Fitzgerald, who will introduce themselves now.
I'm Megan Fitzgerald. I have a doctorate in neuroscience and neurology, and I was conducting research on stem cell biology in March of 2020 when I developed COVID and subsequently long COVID. Part of that kind of first cohort of people with long COVID. And I switched the focus of my research to studying this condition that was affecting me and so many others. I joined the Patient-Led Research Collaborative in late 2020 and worked with them extensively on their reinfection study. I've also worked as a patient representative for the NIH's Recover Initiative and have more recently joined the Brain Inflammation Collaborative to study long COVID and other infection-associated chronic conditions across the lifespan, including in pediatrics. I'll pass it on to whoever's next.
Dr. Amy Proal, how about you?
Hi, I'm Amy Proal. I'm a microbiologist. I'm also the president of PolyBio Research Foundation. We're a nonprofit organization. We conceptualize and we fund research projects on conditions initiated or exacerbated by infection. Those include long COVID, ME/CFS, tick-borne, vector-borne illness, but even the chronic consequences of infection on conditions such as Alzheimer's disease and Parkinson's, for example. I'm also the scientific director of Mount Sinai's Core Clinic, where we work to treat patients with long COVID and other chronic conditions tied to infection. So I look forward to speaking today. Thank you.
Thank you. And Dawna, how about you introduce yourself?
I'm muted. I was muted. My name is Dawna Ballard, and I am a caregiver. My daughter, my 13-year-old daughter, at the time now 15, developed long COVID, and I'm here to speak from a caregiver perspective. I also happen to be a professor of organizational communication at the University of Texas at Austin. It was not by design. I happened to actually even study health communication and never really wanted to be on this side of things. But I look forward to talking more and particularly the Q&A of being of value to people.
Thank you all for being here today. We really appreciate it. Our first presentation today will be from Dr. Fitzgerald and Dr. Proal on the current state of pediatric long COVID research, what we know and where we need to go next. So Dr. Fitzgerald, we'll start with you.
Great, thanks. Let me get my screen set up. Okay. And we're going to go to Can you all see my, is this correct now?
Yeah, go to,
Okay.
we can see your notes.
You can see my notes as well. Got it. Happened before. Okay.
There you go.
Alrighty. Perfect. Thank you so much. All right. I'm going to be speaking about some recent studies in long COVID on children, and as well as the importance of conducting pediatric research on long COVID, like why specifically looking at pediatrics and some of the challenges that researchers in the fields face. Early on in the COVID pandemic, there was a widely held belief that COVID did not affect children, and abundant data, and especially some very recent research data, has shown this to be false. In a large longitudinal long COVID study that just came out in the past week or so, it was based in Italy. 23% of infected pediatric patients up to the age of 18 were diagnosed with long COVID 3 months after their acute infection, and over 7% still had long COVID 2 years later. So this isn't something that is just a flash in the bucket for these kids. This is something that can be affecting them for years of their lives. And this study was conducted based on clinician assessment, which is very different from the NIH's Recover initiative. Which has also recently come out with a large-scale study where they found that 20% of COVID-infected school-age children and 14% of COVID-infected adolescents exceeded their research criteria for this long COVID research index threshold that they had developed in this study. So, as Megan had mentioned, this means that around 6.5 million American children are likely struggling with symptoms of long COVID. The economic impact of this is just tremendous if you stop and think about it. There's been a lot of ink spilled about how bad the economic costs of adults in the workforce with long COVID and how that's affecting the economy and the expense of that. But if you think about what is the cost of someone who is never able to join that workforce, who is never able to participate fully in these programs, the social and work and in other programs and education. And then even to put that aside for a minute and just think about the humanitarian side of things. These are kids who may never know what it's like to grow up in a healthy body, right? So it's just extremely important to study long COVID in kids, but it's also difficult. And one reason that there may have been a kind of historical misunderstanding of pediatric long COVID is because long COVID symptoms are different in children than in adults, and this could lead to underdiagnosis, especially in school-aged children. By school-age children, I'm talking about kids who are between 6 to 11 years as per this Recover definition. And this is, I'm just going to show some data from this recent Recover paper that came out, which both Megan C. and I were patient representatives and worked on over a couple of years to help develop the study design and act as patient consultants. So the way that Recover set up their study was to look at uninfected versus children who were infected with COVID, rather than looking at a clinician diagnosis of long COVID versus people who did not have COVID, in order to have less bias in the sample. And what they found was that there were 14 symptoms that were more common in kids who had a COVID infection than those who didn't. And this was in both school-age children and adolescents. And you can see some of these do recapitulate some of the symptoms that are seen in adults, like problems sleeping, tiredness and sleepiness, low energy, poor appetite, feeling tired after any exertion like walking. There are mood problems too, like feeling depressed or anxious, cardiovascular issues, lightheaded or dizzy on standing, stomach problems, and pain generally. But there were a couple of things that stood out in the younger kids, the cohort in 6 to 11, as opposed to those who had remained uninfected with COVID. For example, there was more school refusal, more palpitations, and more dermatologic symptoms like itchy skin or skin rash, whereas the older children, ages 12 to 17 years old, were more likely to report a change or loss of smell or taste. And then once they broke up the data and looked at these different clusters of children who were likely to have long COVID. So in the paper, this is termed PASC probable, and PASC is a research word that a number of researchers and clinicians are using, and it means the same thing as long COVID. And what they found is that there were clusters in school-age children, clusters of symptoms that were 6 to 11 years old that were distinct from those that they saw in adolescents who were 12 to 17 years old in this study, like trouble sleeping, trouble with memory, focusing, and a lot more GI symptoms like stomach pain and nausea and vomiting. Whereas, again, the adolescents were more likely to report change or loss of smell or taste. And there was, across both groups, there were many symptoms, including pain and fatigue and low energy. And again, that is similar to what is being seen in adults. Right, so I just want to take a minute and talk about this study from a patient perspective. And, you know, I'm a patient who got sick in the first wave of COVID. So for over 4 years now, we've been trying to describe long COVID to clinicians and researchers. And it can sometimes feel like you're trying to describe how the sky is blue to somebody who can only see black and white. They don't even know what the color blue looks like. And if you've ever experienced long COVID fatigue, you know how hard it is to describe to people who say, oh, well, everyone's just tired, right? It's a different thing, and it can be really hard to communicate this. So when these huge research efforts come out, like this recent Recover publication, and it can be validated. You can be like, there it is, you know, that's what it looks like. This is the cluster of symptoms. It's defined. You can feel seen, right? But then the next feeling is kind of like, okay, so what? I already know that I'm sick. I know other people are sick. So why is this work so important? Why are we spending these resources on this research? You know, we already know we have the symptoms, and they're not just a list on a page for us. They encompass a lot of suffering, right? There are dreams that have been deferred for years, and so much of our lives and our children's lives that we've had to put on hold to deal with this illness, right? We want clinical trials, we want treatments. And these studies, however, you know, especially in pediatrics, where a lot of this work has not been done before, they're important for a number of reasons. Even if we, you know, we do want to rush ahead to treatments and clinical trials and therapeutics. First, these studies of symptomatology and prevalence, they can inform public policy. And secondly, in order to have clinical trials, even, you know, studies that are going to discover disease biomarkers, we need to have a clear understanding of what the disease looks like. We need to have something that can be reproducible, a definition across, you know, across different trials, across the country, across different populations, and we need proper clinical trial endpoint instruments. It's so frustrating when you hear these stories from patients, some of whom have ME, which is a different infection-associated chronic condition that many people with long COVID have as well, and they seem to report great results from clinical trials that then fail. And you wonder, what was the clinical trial endpoint of that? And if we're not using the right instruments, if we're not using the right clinical trial endpoints, these very expensive research-based clinical trials are not going to succeed. And that's really the importance of this study, so that we can have a clinical definition of this disease, which still lacks biomarkers, and we can have good clinical trials, and so that we can improve public policy. So I'll spend the rest of my talk just circling around and expanding on those points in the pediatric population especially. So the first thing I wanted to touch upon in terms of policy, and I did debate putting this in here because it's not strictly related to the research on long COVID, but it's something that touches all of us as parents and caregivers so intently every day. And we really need acknowledgement from education policymakers that COVID and long COVID, and not just pandemic-related school closures, have an impact on learning. And this is often referred to as this pandemic learning loss, and it's dealt with by these strict policies that focus on school attendance. This is it's just some language lifted from a local website in a school district that's near me in New York State. And you can just see all of this emphasis on attendance, perfect attendance, telling you to you schedule doctor's appointments and dentist appointments outside of school hours. And I don't know what pediatricians and dentists they go to, but mine certainly don't have weekend hours. And so it's just incredibly hard on parents who are dealing with sick kids. And one reaction to the pandemic seems to be that there really isn't guidance on when to keep kids home when they're sick, and this exacerbates the problem of illness in schools. This exacerbates this learning loss, especially when you're forcing vulnerable kids to go to school around parents who feel pressured to send their own sick and contagious kids to school. So presenteeism is a big problem in schools. And it doesn't just affect the kids. K through 12 teachers have the highest prevalence of long COVID among professionals surveyed, and this is in multiple studies that have been done recently, including one that PLRC recently conducted on reinfections. Policymakers don't always believe sick children, educators, or parents, but they're going to listen to the NIH, and that's one reason that this Recover Pediatric study is so important. And I just want to highlight as well, this is one way that, just a couple months of illness for kids is different from a couple months of illness for adults. And we know long COVID can go on for longer than that, but say even it's fairly mild and does resolve in a couple of months for a child, it can really set them behind in school. And if these illnesses happen in critical points of development, this can really be a problem biologically for the kids as well as socially. And so I just wanted to touch upon the importance of these longitudinal studies in pediatric populations, because there are critical stages in the neurodevelopment of infants, children, adolescents. This starts in prenatal life and extends through young adulthood. And during these critical stages of neurodevelopment, the brain is vulnerable to stressors, including infections, and these stressors can have outsized and long-term consequences. This little chart here is from a review. It's on different infectious agents when a mother was pregnant, and the risk of schizophrenia and other severe psychotic disorders developing in adult offspring. So this is, a 20-year gap between when the pregnant mother was exposed to these infectious agents and the development of mental health problems, serious mental health problems in adults, her adult child. So this is showing, influenza having an odds ratio of 7 in the development of schizophrenia, as compared with someone who was uninfected. And we don't know what the long-term effects of a COVID infection is during these critical times of development. And we need to figure that out. And the best way to do that is with longitudinal studies. But these longitudinal studies in children can be really difficult and expensive to conduct, because you're trying to understand the natural course of the disease across development. It's a lot of reporting the impact of infections during these critical periods, which we don't know exactly when these critical periods are going to be with a COVID infection. Like with Zika, it's the infection during one trimester of pregnancy. It can be deadly or lethal for an infant, developing infant. We don't know what that is with COVID yet. what the impact is during adolescence, childhood, prenatal development, infancy. How are these symptoms going to present differently across the lifespan, and what the long-term outcomes of these diseases are? So this is very expensive work to do, and very difficult work, but very necessary work. And as Megan mentioned, kids aren't just small adults. There are challenges that are unique to pediatric research because pediatrics encompasses many stages of development, from newborn and infancy, toddlers, and early childhood, school age and middle childhood, which my son currently is, preteens, adolescents, teenagers, and even early adulthood. And as the Recover work showed, the long COVID symptoms are going to present differently across the pediatric developmental spectrum. There might be delays in walking and talking for toddlers, whereas there might be mood disturbances, fatigue, headaches in teenagers. Even the screening tools need to be tailored for different populations. The language that we're using can't be the same for children and teenagers. For younger kids, it's going to rely on caregiver reports. So that's a whole separate set of screening tools and instruments. Treatments might need to be age-specific, and clinical trial endpoints must be age-specific. Treatments might not only decrease in dose, but there might be some that might not even be able to be administered to younger children due to the mode of administration, the immune response of younger kids versus older kids, metabolism, and this can present complications when we're setting up clinical trials. There are also a lot of ethical considerations to pediatric research, and because of this, it can make the research even more expensive and difficult to do, because rightly so, institutional review boards or IRBs pay special attention to pediatric research. As an example, caregivers must often be present when you're conducting pediatric research, but that needs to be assessed carefully. I mean, would a teenager necessarily feel comfortable speaking about menstrual health changes or mental health in front of a parent? So this needs to be assessed on a case-by-case basis, and some of these symptoms might even be underreported clinically because of some of these considerations. But we're trudging ahead, and we're taking this all into consideration, and there's a lot of ongoing work and future directions in pediatric long COVID research. As I'd mentioned, I've recently joined the Brain Inflammation Collaborative. We're developing a digital health platform to achieve a better understanding of the behavioral manifestations and mental health consequences of long COVID in children. And we're not just looking at long COVID, we're also comparing long COVID with other infection-associated chronic conditions like PANS and PANDAS, which can develop after a strep infection, ME, Lyme, and others across the lifespan. Because we know that long COVID probably has a lot in common with these other infection-associated chronic conditions. Recover is also having ongoing longitudinal studies of long COVID in children, and this is not only going to include the kind of symptom-based work that I presented, but also some pathobiology work and clinical assessments, and they are moving towards pediatric clinical trials. So if you're interested in any of this, I'd encourage you to visit braininflammation.org. You can sign up for a newsletter and find out about future studies for children and adults with infection-associated chronic conditions, including long COVID, and the Recover COVID info. And they are still recruiting children and young adults, I believe up to the age of 25, through the end of this calendar year. I want to thank so much these patient participants and caregivers, both as a researcher in this topic, but also as a patient. I just want to say thank you so much for everyone who's volunteering for these studies and to take part and to build this database. This is what we need in order to have cures. We need our participation. So thank you all so much who are volunteering. This is for these studies, it's one of the best things that we can do to work towards treatments. I want to thank Megan and Long COVID Families for hosting this seminar, and the Brain Inflammation Collaborative, my new colleagues, Christy, Denise, and so many others who are really dedicated to this mission, as well as Patient-Led Research Collaborative, who stepped up to the plate and defined this condition in spite of so much opposition from the research establishment. And the Recover Initiative as well. I want to call out Rachel Gross and Melissa Stockwell in particular, who are heading the pediatric research committees that Megan and I have sat on, because they've really, it can be hard to work with researchers who aren't used to working with patients, but Dr. Gross and Stockwell have really done a great job, not only of incorporating patient input, but of respecting it and of asking for it and coming to Megan and I and other patients for our input. And I'm not sure if we're doing questions now or if we're doing them after Amy has spoken, but I can.
Yeah, we'll take them after Amy has spoken. So if
Okay,
anybody has
perfect.
questions for Dr. Fitzgerald, be sure to put them in the comments. Thank you for that. That was amazing. I really appreciate it.
Thank you all.
All right. And we'll pass it to Dr. Proal.
Okay, so I'm going to talk about pediatric long COVID. I'm actually just going to go over two central possible drivers. They're very straightforward, which is why I thought they would make sense to just review in the kind of shorter amount of time that we have today. One is the persistence of the SARS-CoV-2 virus in body sites like gut tissue or other tissue sites of the body. After acute infection, we call those tissue reservoirs of SARS-CoV-2. And the other is reactivation of previously latent pathogens, such as Epstein-Barr virus, or potentially a tick-borne, vector-borne infection, such as Bartonella, which I'll talk about later. Often it's really straightforward when a person or a child gets infected with SARS-CoV-2, the virus downregulates or disables so many parts of the immune response in order to drive disease. Some of the signaling that it knocks down on the side of the immune system is interferon signaling, these molecules that are really important in the control of many different kinds of infection, especially, other viral infections. And so what that allows, and we see, this hasn't been investigated as much in pediatric long COVID as I'd like to see, but it's definitely been shown in adults with long COVID that we see reactivation then of pathogens such as Epstein-Barr virus, other herpes viruses, or other organisms in patients, and that can be one of the reasons that chronic symptoms also happen. So to discuss the first topic, which is SARS-CoV-2 persistence, this is a group that we've pulled together. Actually, it's our PolyBio Long COVID Research Consortium. We're scientists at different academic institutions around the world, from a couple different countries, from France, from England, now from Belgium, from the UK, all working on long COVID. Together, we wrote this paper. It was several months ago now, just reviewing evidence for SARS-CoV-2 reservoir or SARS-CoV-2 persistence in post-acute sequelae of COVID PASC or long COVID. And this is a table taken from that paper. These are just some of the studies that have shown or identified persistent SARS-CoV-2 RNA or protein in tissue samples, and in some cases in blood, and I'll explain that a little bit in a bit, from people up to hundreds of days after COVID. They stem from olfactory tissue in the nose in patients with loss of smell, or taste bud tissue in the tongue of patients with loss of taste. There was actually an NIH study that still found SARS-CoV-2 RNA in the taste bud tissue of every single person in their study who had loss of taste. And then many, many other types of tissue with a focus. We look highly at the gut. One of the reasons for that is that the gut is dense with the ACE2 receptors that SARS-CoV-2 uses for entry into cells. And also SARS-CoV-2 often reaches the gut in people who are infected. So we all know that a lot of people who get COVID develop GI symptoms, but we also know that wastewater is even used to track COVID in areas. And that's because it's getting into the gut unless it's in stool, right? So this is a group at UCSF who recently published this really amazing paper. This is in adult patients, but I think that the overall trends can pertain to pediatric long COVID, where they looked at, in one part of the study, they looked at gut tissue obtained from patients after COVID, including patients with long COVID symptoms. And this is one of the images from their paper. You can see that you have here SARS-CoV-2 double-stranded RNA, which is actually created during active virus replication. So it's part of the virus backbone that should really only be there when the virus is making new copies of itself. That's what's in the gut tissue of these patients with post-COVID or long COVID symptoms. In one case, 442 days after initial infection, and on the right here, you can see 676 days after COVID. They found this up to 2 years, actually, in certain patients. And on the right, you can see really, especially, that the infected cells are inside often, they're clustered together. Some of them are inside the cells of the immune system, such as macrophage, where they're essentially hiding out in a way protected from the immune system. It's a Trojan horse mechanism in a sense, where a pathogen like SARS-CoV-2 here is actually infecting and persisting inside the cells of the immune system that should otherwise eradicate it. And there's a cluster of immune cells there, which actually led the team to nickname this a coronaloma, because it's very similar-ish to a granuloma, which is a ball, for example, an infected a sort of structure of immune cells that is, for example, formed in patients with tuberculosis when they have chronic infection. So, we see this clear proof, and just shout out to this study, if you end up reading it, they also used a form of imaging to look at T cell activation throughout the bodies and brains of patients, and they found increased T cell activation in all kinds of body sites in these post-COVID individuals, including in the spinal cord, in the bone marrow, in their tonsils, in the nose, again, the colon. So really key, and this definitely pertains to pediatric long COVID, is that the long COVID disease process definitely is not only happening, for example, in blood. It's happening throughout the bodies and brains of patients. It's happening in their tissues. It's happening in the central nervous system, potentially, maybe even in the bone marrow. And that's why we need so much research on it, because it's not as simple, as you all know, as getting blood from a person or a child with long COVID, running some tests and finding something wrong. We need to do a lot of in-depth analysis, including, for example, the gut biopsy work or the imaging work done by this team to really identify the dysfunction in people who are sick. This is work that has been done, again, this is in adults with long COVID, but these are teams that have found the SARS-CoV-2 proteins, so like spike, nucleocapsid, S1 proteins in blood from people with long COVID, again, up to about 14 months after initial infection, I think, in one study. These are studies where vaccination is controlled for very well. For example, the study in purple there on the left, most of the participants hadn't even been vaccinated. So it's not a confounding effect, for example, if spike protein is identified. And what we think is happening, and it's still a hypothesis, is that virus persists after initial illness in the patient, but it sometimes translates protein, which leaks into the circulation, into the blood, where it can sometimes be measured if the team has a sensitive enough test, which is what a lot of the teams whose studies you can see on this slide are using. This does matter because Leo Yonker's team, who's part of our consortium, who's at Harvard Mass General, who's incredible, they're running a clinical trial that we're supporting at PolyBio and we're really excited about, where they're testing liraglutide, which is a drug that repairs gut barrier function in children with long COVID. And the basis of the trial is that early on in COVID, they were working with David Walt, who is one of the teams who has one of these really sensitive tests for spike and other proteins in blood. And they found in children with MIS-C and in some early long COVID patients, they found spike in those kids still in their blood, or RNA, viral RNA in their guts after acute infection. And so they hypothesized that what might be happening is that this protein, persistent protein or RNA from the virus in the gut actually is able to leak into blood. Well, it could cause inflammation that makes the gut barrier, potentially wears it down, leaky gut due to that persistent virus. And then that allows spike to leak into the blood where it can be measured, but then it can drive so many downstream consequences. It can activate the immune system. It can drive clotting problems. It can drive blood vessel problems. It can cause all kinds of other effects. So the goal of the trial is to try to use a drug to improve the permeability or the structure of the gut lining to prevent that spike protein leakage into blood. But when they're recruiting patients, children now into this trial, it requires proof of spike protein in blood to enter the trial, which tells you that at least this one Harvard group is finding spike protein regularly in children with long COVID. So this is something that we have to follow up on. And one of our main goals, I'll just make this point a million times over, is that at PolyBio is to take these tests that can find small amounts of spike protein or viral RNA and really work on getting them into the clinic so that we can use them on children or any patient so that we can show doctors that there really is something wrong. So this is an example. This is Mike Van Alzeker's lab at Harvard Medical School, who also works with us at PolyBio. This is in adult patients, but Leo Yonker's lab is also working on the same stuff in kids. This is, on the left, you can see these are activated platelets. This is done via microscopy. So they stain for platelets, which are actually, the blue on the left is neutrophil extracellular trap. So what happens is that, let's say a protein like spike leaks into the blood. There are immune cells in the blood called neutrophils, and those cells often come in and try to trap protein or pathogens. Actually, it's part of the immune system's response to them. If they do that, they form these projections that trap the pathogen or the spike protein, for example, and that's a net, a neutrophil extracellular trap. So this is blood from a long COVID patient, and you can see that this blue stain for nets is lit up. So there's net formation happening, likely in response to spike. We're continuing to study that, but probably. And then on the right, you can see this is a red stain for platelet activation, and platelets are small red blood cells that are involved in clotting processes. And you can see here that the platelet activation is just overlaid with the net formation. So we have this direct relationship between potential spike protein leakage in the blood, activation of these nets, activation of platelets, and all of that's going to cause potentially a lot of downstream problems, a lot of symptoms. That's maybe where the symptoms that really start to come in people who have persistent virus or persistent spike protein issues. And just to go over a couple other studies that show evidence of persistence in children. This was a group, Dan Cherto's group was part of this. He's an amazing researcher at NIH. They got lymph node tissue samples from children with long COVID. They looked for viral RNA in those samples from their lymph nodes, or actually their tonsils too. It was tonsil adenoid, and which are part of the lymph node tissue. And they found RNA in many of the tonsil samples. So I think in 7 out of 9 adenoid samples, you can see here, going back there. And then in a good number, also 15 out of the 22 tonsil samples. And there were changes in the immune response of these tonsil samples too, suggesting that the persistent RNA that was still identified in these tonsil samples in these children was probably modulating the immune response. And we're still studying what that means, right? But the thing is that these were just kids undergoing routine surgeries to get their tonsils removed. And this is just a team that checked to actually see if there was virus there, and there was in a lot of people. So really, if we actually check how many kids are hanging on to viral RNA, and it's just something we need to continue to look at. Okay. And then this is another study that just came out. This is still a preprint. What this group did, this is the paper. They got gut tissue from children. These were children who had GI symptoms after COVID. The average age of the kids in the study was 14 years of age. They got this, it's mostly tissue samples from the colon. And when they got those samples and examined them, of 30 patients whose colon samples they examined, 50% had positive SARS-CoV-2 nucleocapsid antibody RNA. So they stained for that, and they could find this, nucleocapsid antibody, which, nucleocapsid is only created by the virus. It's not part of the vaccine or anything like that. So that this is a clear evidence of viral persistence. Then they also did a transcriptomics, which is a gene analysis using a technique called RNA-seq. And they were able to show that in kids who had persistent virus versus samples from the pre-COVID children who had IBS, actually, there were differences in the way that genes were upregulated or downregulated near the identified virus, including those associated with controlling the immune response. They also just found some increased signs of inflammation, for example, near the virus in the tissue of the kids who had it in their gut samples. And so they said, we present clear clinical histologic and RNA transcriptomic evidence of a novel SARS-CoV-2 syndrome predicated on a local inflammatory response to persistent viral presence in the intestinal epithelium. We have titled these phenomena SARS-CoV-2 persistent intestinal epithelial syndrome, or SPIES. So this group actually named a new, diagnosis or disease because of what they were seeing in these kids. It's similar to IBS, but not all the immune changes were similar. So it's kind of like a new onset thing they're seeing in these children with persistent SARS-CoV-2. So last, I wanted to comment that we are seeing in adults a SARS-CoV-2 spike in RNA and platelets, which are cells of the immune system. So there's potential that we might be able to follow this up in kids and be able to measure platelets, which are circulating in blood, which is interesting. They're host cells that are actually derived from the bone marrow. So this team actually also is finding in adults SARS-CoV-2 spike in that double-stranded RNA indicative of active viral replication in bone marrow cells, which are megakaryocytes from adult patients with long COVID. So we are interested in this relationship where potential persistence in the bone marrow might be an issue in some of the more serious cases of people who are sick. This is a team that also found SARS-CoV-2 transcripts in long COVID blood using another technique that we think is really interesting and we're looking at as a diagnostic. But, since my time is coming up here, I just want to go quickly to that last trend I mentioned before, where another thing we look at is just the ability of SARS-CoV-2 to essentially unmask infections that a person might have had before, but they weren't symptomatic yet. So all of us, we start to acquire infections starting in the womb even. So we are past, herpes viruses, for example, from our mothers, even in some cases from fathers via sperm, and children essentially, yes, are seated in the womb with a certain number of pathogens that they have. And then across the courses of our lifetimes, we acquire other infections. Many of these, let's say, for example, Epstein-Barr virus, are often dormant. So what happens is the immune system keeps them in check, right? And so they're not able to do much because our immune systems are strong, keeping them down. But obviously, if something disturbs the immune system, this could be a SARS-CoV-2 infection, maybe in some cases a vaccine, it depends, right, which is an immune challenge. That pathogen that was previously latent might have an opportunity to resurface and actually begin to drive symptoms. And this is a case history from a team that found that a person with long COVID tested positive for Bartonella henselae, which is a tick-borne, is a vector-borne infection. It can actually be acquired, it can be acquired via a tick, but also via a spider bite, via fleas, via a cat. There's so many vectors of Bartonella that are not well understood. And when this person was treated for Bartonella, the symptoms of what had been diagnosed as their long COVID improved, right? So it's really important to the greatest degree possible that we test children to the greatest degree we can for these other pathogens. The testing isn't perfect, but there's some labs where you can start, and it's another goal at PolyBio to create better technology to be able to find these pathogens in both adults and children. So thank you very much.
Wow, thank you so much for that. Thank you both. I'm still actually processing. That was great information. Research is so vital to understand pediatric long COVID, but it's also as an education and advocacy tool, really. So it's both exciting and frustrating to see how much potential, as well as how far we've come with the adoption of the new technologies. But at the same time, I know far too many of us, we know what the doctor's office is like for us patients. And, that's really where the rubber meets the road, and research and diagnostic tools are only as powerful as their uptake.
Yep.
At this moment, far too often, it is the patients that are educating the doctors about pediatric long COVID, and we need to turn that around. So next, I will have a conversation with the amazing parent advocate about her experience and perspective on what needs to happen next in provider education. Dawna, welcome. So tell us about your journey as a long COVID caregiver.
Thank you so much.
Yeah.
I also am still processing. So thank you for saying that, because I'm blown away, and wow. Yeah, and just a little bit emotional. So the thing about it, and I see that several of the people, I can't tell who exactly is here, but they know what long COVID is like in a child. So I'm gonna start, and I'm gonna time myself. I'm gonna start with, okay, thank you. Wow, because that was just like, wow, with exactly what you just said. Is I was asked to identify like what would be an ideal area of research in long COVID. And as a social scientist and not a medical scientist, my first thought was what you just said, is that all of this work that is so valuable, like, my goodness, like, I think that's part of just where I'm just feeling like, my goodness, this is out here and people don't know. So the thing about long COVID that is particularly unique, it might be similar to other illnesses, but misdiagnosis is such a dangerous thing. Our first diagnosis was gastroparesis, and it was so definitive. And now I learned, yeah, it wasn't that, but the thing that you do with a lot of pediatric GI issues is that, which is, as you both mentioned, this is a lot of the symptoms are very often GI related. Well, they tell you, push them to school so it'll take their mind off of it. Push them. It's just, and all of the cognitive behavioral therapy, all of that stuff, which, while it has a place, that pushing in the earliest days. So my daughter came back from a school trip in March 2022. And most of the people, the teachers and counselors and staff and the students, it was an 8th grade graduation trip. A lot of them had COVID, at least half of the people had COVID, and she got COVID as well. And she actually seemed to clear the illness pretty quickly. She, I thought, oh, great, her great immune system. She was vaxxed and boosted, and oh, this is great. And so I, because of my ignorance, didn't think when she got sick days later, and then that didn't resolve, I didn't think long COVID because I had seen that window where, oh, she's fine. And now it's this other stomach virus, and her friend got that other stomach virus and he got rid of it in 24 hours. She was bedridden for pretty much the rest of her 8th grade year. This was a graduation year. And so she was literally, and I will just say this in case there is anyone exactly who doesn't know exactly what when we say our kids are bedridden, they're not in bed texting and watching TV and sitting up. They're in the fetal position. My daughter was in the fetal position for weeks. And so, we did we saw the pediatrician frontline, and they ran a bunch of labs. And as you point out, you're not going to see it in the labs, but they believed us, and, like, something's wrong. And so then I kind of pushed my way in to get into a gastroenterologist soon, because otherwise, again, time, you can usually see a pediatrician same day, but the specialist can take months, many months. And so I pretty much said, I know you have a cancellation, and my daughter's been sick for 2 weeks straight, and I will call you every day, morning and evening, until someone sees my child, because she's really sick. And so we got in, and we got the great misdiagnosis of gastroparesis. And that brings me to the thing that we can do, that research can and should do, is focus on the interorganizational collaboration. So that, and I sort of charted it out, but you have the nonprofit advocacy educational groups, right? Like Long COVID Families, and you had mentioned the Patient-Led Research Collaborative. Absolutely. They're agile, they're small, they're the most educated on this. They're people who know how to read research and who are motivated, and they take the time to do that. Because from the time I found Long COVID Families, it was only several months. I mean, it's like from 9 months of just nothing. From the time I found Long COVID Families, we were within 6 months, and we're really seeing improvement. And so, but it's like, and so there's that arm, and then the researchers, those of you who are doing the work funded by government agencies. So those big organizational structures of the agencies and the researchers that they're funding, the advocacy nonprofit groups, and then news organizations. Because let me tell you, and I thank you so much for the first presentation that talked about presenteeism and absenteeism. One of the things that has just blown my mind is the reporting from reputable news organizations saying post-COVID, there was one headline that said school is optional for kids post-COVID because they see that kids aren't going to school. And so they're making up these stories that are uninformed and uneducated that parents are just lax now. Obviously, none of that has changed. It's sick kids. And if those news organizations had a way to communicate with these other groups, then instead of the headline being that long COVID is not real, I remember reading that in a story, but also just, oh, kids aren't going to school. And now school districts are really, public school districts are really kind of reinforcing, and like they're really getting kind of crazy about attendance. At least I can say here in Austin, they're getting very intense about it. The communication among those stakeholders could lead to the frontline doctors and the schools knowing what to do, and parents. And let me say, I said I studied health communication. This year alone, I published 3 articles on time scarcity in general practitioners and family practice medicine. These aren't people who are hateful and don't care. They barely have enough time to do their basic job. So for us to think that individual doctors are going to keep up with this, no, it has to be at an institutional level. In my view, like there's professional associations, there has to be an institutional drive to take this seriously. And I just want to say we have a model for this. So you might know, oh, how are you going to coordinate all of those various stakeholders? I'm on the board of directors for the Children's Advocacy Centers of Texas. And this is a global movement. They're part of a global movement around the world where they came together to support children affected by child abuse, because these multiple organizations, government agencies and nonprofits, they weren't working well together and children were dying at the hands of their abusers, and they have fixed it. It is possible. There is a model. It wouldn't be exactly the same, but inter-organizational collaborations can happen. And I just feel like our public health colleagues, I would really love them to get funded to do research on how to bring your brilliant medical research into people's hands so that people are getting diagnosed early, because that seems to be the biggest thing with long COVID. If my child could have known just radical rest, which we learned from long COVID families. Do you know what I mean? Like if we, I mean, like, you know what I'm saying? Like, this is like huge. What a difference that could have made. So anyway, so that, let's see, I might be at my 10 minutes. But, oh no, I have a couple more minutes. So beyond that, our kind of and see, to me, that's a simpler approach. You guys are doing the complex work of the actual medical research, but a simple approach is you just get this information quickly to the people who need it, because we're about 18 months into this journey. And so we're looking April, May, I did a kind of timeline. April, May 2022, we're seeing a pediatrician and a gastroenterologist, and we're being pushed to school. And she immediately rebounded. Every time she went to school, she came home worse, and we didn't understand why. And obviously I understand why now, but we get this misdiagnosis. June and July, as you might imagine, she started feeling better because she didn't have the stressors she was getting to sleep in. So we thought, and the doctor said, oh, she's getting better. Just wait, it's just time, it's gastroparesis. But I went and got 2 new general practitioners for her, both MDs, but one has like a holistic approach. I was looking into supplementation. We went to physical therapy, to acupuncture to figure this out. August, her freshman year, she feels fine. That first day she goes to school. She's a kid that loves school and she's so excited. She comes home, I mean, so excited, and she can't get out of bed the next day. and that she missed the vast majority of her first semester of her freshman year. And so during that time, that first doctor just was like, push her. I don't know. I can't tell you. And she literally just sent us home with like, figure it out. I don't know what to tell you. I've given you enough drugs. I don't know what to do. And I'm fortunate. I have a lot of friends and colleagues who are doctors. And so I asked one of my colleagues, what would you do if this was your kid? And he said, and this was in September, he said, get a second opinion. So we got in line. Again, specialists can take so long. If we're not getting to the family practice and the pediatricians, the specialists can take so long to get into. So we got in line to see a doctor in Houston, and we waited. And then in November, we got to see a new doctor. And a tip that I learned is, because, you know, driving for, especially, we're really fortunate, we're in a metropolitan area, but we were willing to drive. But a friend said, or actually one of her doctors said, rather than going all the way to Houston, why not ask her doctor, do you have a colleague who has more experience treating patients like Layla? And that changed things for us, because we then got in with, and again, it took many months, but we got in to see a really good gastroenterologist who freaking cared. And so, but he immediately suspected long COVID, but he didn't know what to do. He didn't know really what that meant. It's like, oh, I can see that this is long COVID. Let's treat the symptoms, but he didn't think about POTS. So her eventual diagnosis that really, really helped was POTS. But he sent her out for a neuro consult thinking they'll catch any of that stuff. The neuro people were asleep behind the wheel, did nothing. So that's November. Now, January, we get confirmed long COVID. The gastroparesis did not bear out. That's when I found long COVID families. She went into full-time homebound. Well, I'll say a hybrid. And I will recommend for those of you whose kids have to be in homebound, you can make a hybrid scenario. So she was able to go to some classes sometimes, never always, because she didn't feel well enough, but she kept her art electives. And so she got to be, because as you mentioned, developmentally, this is such a big deal that these kids be able to live their lives. So she was able to, by March, I got a functional doctor even in March, asked them about POTS. He said, no, she's not fainting. She doesn't have POTS. In June, I got a heart rate monitor for her because I was tracking the ME/CFS part of it and wanting her to pace herself. And one moment I was looking at it, she stands up. I just happened to be looking, she stands up and her heart rate went up over 50 points. And I said, this is POTS, you know, like, and I was so fortunate. This was the best case scenario. They had just opened a new children's hospital. And it's the Texas Children's Hospital in Austin. So I was able to get in quickly. I was able to see a neurologist pretty quickly, and a cardiologist. The neurologist and the cardiologist were able to confirm the diagnosis, and the cardiologist could give her medication to treat her. But this all happened right up until the day, August, when school started. And I will say this, she went 2 full weeks to school for her sophomore year. Every day felt like she was tired. It's don't get me wrong, but she was able to make it. At the end of 2 weeks, she did get COVID, but guess what? Yeah, and at first I was like, you're making this up. This can't be happening. But we know different things now. I'm doing things differently. That's the thing. Like, I don't want to live our lives in fear of COVID, because it's just everywhere. That's no way to live for your nervous system either. You can't just be afraid, but we know what to do. We know we have resources now. So she's still home. I've kept her home even though she feels fine. And we've had a transitional homebound, and I'm letting her rest and rest and rest. So that's my story. And those are my comments. Thank you so much for including me. And thank you so much for everyone here who's doing the research, and to long COVID families for the advocacy work. I mean, it's life-changing for people.
Oh, thank you so much. Thank you for sharing that. I mean, thank you. I think if you can see in the comments, it resonated with so many people. Thank you very much for sharing your story, your perspective, some of your ideas about how we can move forward and do this better. Like, it's a great idea. I would be really interested in doing it. It was so powerful. And I hope it's, I said yesterday on another panel, I hope this is a wake-up call between the research and what we're finding, and our kids and families desperately need the support. And I hope that we have people listening on this call that are going to hear what the reality really is for patients and parents trying to get help for their kids. I mean, the idea that our families are fighting schools is heartbreaking, but that's the reality. Is it feels like we're in this locked battle over it. And hopefully that starts to shift. So thank you for that. But at this time, I'm so very pleased to now open up the session to a dialogue with everybody, and open it up to start taking questions. So if you haven't already, please drop your questions in the comments. Someone will be collecting them. We will go ahead and start with, this will be just open to all panelists. So what do we think about pediatric clinical trials? What do you want to see in the near future? Go for it.
I'll let Amy talk about some of the antiviral ones, which I'm excited about, but I'll focus on a couple of other ones that I would like to see. I would like to see a clinical trial for Mestinon because it is over the counter, it is inexpensive, and it can really help a lot of us with symptoms like POTS, like the fatigue that's so disabling for kids, and it's cheap. So it's something that can be prescribed quickly. It's very low risk too. You get some GI side effects, but they wash out quickly. So I think with pediatrics, it's really important that these are pretty low risk therapies and clinical trials. So if there is a clinical trial for that, we could expect pretty quick translation and adaptation of a treatment for a kid. So that's one that I would push for. I would also be excited for a clinical trial for low dose naltrexone, which has had a lot of success treating or alleviating some symptoms for adults. And it's just really hard to get. You have to go to a compounding pharmacy. A lot of people are not familiar with it. And so something like that could just move the needle. Again, like get kids from being homebound to being able to participate in life again, even if they aren't fully better. And I would think Mestinon's in that same thing. So we're looking at some symptom relief rather than potentially curative things. But it can make a huge difference, and then you get in that virtuous cycle of being able to do healthy things for your body again. So these can be really difficult to get prescribed. I'd also like to see now another one that I'd really like to see is IVIG. Now this one is expensive. Insurers don't like to cover it, but it has been shown to help PANS and PANDAS and other things in kids. It's pretty safe, and so I really do want to see a clinical trial for that too to kind of move the needle on that one. And I think Amy, I'm sure you have things to say about the other antivirals and stuff, so I'll pass it on to you because I'm excited about some of that too. But
Sure. I mean, no, I agree with those trials. I think those make a lot of sense. I think there's a balance between trials that would help with symptom management and trials that try to get at root cause, and we need all of them. I think that, on our side, when looking at, let's say, SARS-CoV-2 persistence or the effects of other pathogens, SARS-CoV-2 persistence is, we've focused a lot of our efforts on that in adults because it's sort of low-hanging fruit. We want to figure out, it's like when you get an infection and you don't recover, the more straightforward scenario really is in a way like maybe you didn't fully clear the organism, right? And so we just want to make sure we're accounting for that. And the thing is, if it's still there, we can pull from the knowledge, let's say even the HIV community, which we're already doing, or even let's say the MTB, mycobacteria tuberculosis community, who have a huge amount of knowledge in terms of treating a persistent organism that hasn't fully cleared from tissue. And what those trials often involve are either longer dosing of the drug or a combination of drugs. And so that's at least what we're trying to move forward in adults. I think the key considerations are going to be that even in adults, when we're looking at antivirals and we're looking at extended courses, there's safety data there that has to be tested even in adults, right? And knowing, in kids, again, like the side effects of those drugs is important. So I think that what's needed is a lot of parallel efforts. I think we can move forward, and we are. So for example, in adult long COVID, there's a monoclonal antibody trial happening for persistent virus at UCSF. They're doing Shinogi's antiviral, which is great. There's 4 Paxlovid trials, which there's going to be subsets. Maybe I don't think any of them are going to meet their primary endpoints. This is a long story, but some patients might benefit, which is a trend we think. Again, maybe I'll make this point here too. I think this is one of the biggest things we need to consider with clinical trials for adults and kids with long COVID is that it's a heterogeneous group of patients, right? And different things can be happening in different patients. That makes it somewhat hard for clinical trials if you don't have specific biomarkers, because the whole group might not meet the primary endpoint of the trial. But what we want to emphasize is that there may be subgroups of people who do in trials. So in adult long COVID in trials, what we're doing is pilot trials where we're recruiting people in based on symptoms, but we're measuring so many things in them over time so that if people respond, we can go back and say, it was the people who had spike protein in their blood that responded, or, it was the people that had coagulation issues that were the response. And then we can use that data to identify tighter groups of patients that can go into the larger trials that might, meet those larger endpoints. That's really going to matter because we don't want trials that don't meet their primary endpoint to just, to say, that therapeutic doesn't matter just because it didn't help every kid across the board, right? We want to know from the beginning that probably a subset of kids are going to benefit from each type of drug, right? I think that's just the mindset we have to go into this with. I think on the side of our side too, we're interested in also approaches to address coagulation. So we have a fibrin deposition. There was a really good a paper that came out in Nature that showed that fibrin and spike protein are really interconnected, and in the spike seeds fibrin, which is part of clotting processes, and a lot of that's similar to the microclots that a lot of you may have heard of that have been identified in long COVID blood. That I think, Leo Yonkers' lab has found those fibrin deposits. We have a trial at Sinai where we're using a supplement called lumbrokinase that breaks up fibrin. This is in adults, right? And we're starting our trial. We'll see how it goes. I think I'm optimistic that kids, we'd have to, again, work with the manufacturer of the supplement and stuff to really understand again, the safety in children, but that combining drugs that disrupt fibrin or help with blood vessel function too, because we see a lot of effect from spike on those processes, might be helpful as part of trials as well. So those are all,
That's really interesting.
things.
Could you also talk a little bit more about what Dr. Yonkers doing?
Yeah, that's a trial where they're hoping that if kids have a reservoir and haven't fully cleared the virus in their guts, that they think that part of the issue is that the reservoir, the inflammation associated with the persistence might help wear down the gut lining. And now you have leaky gut, and now spike is leaking into blood, and then that catalyzes like those nets that I was showing, the platelet activation, all of that just gets set off, which can cause this wide range of symptoms. So if they're trialing a therapeutic that can hopefully repair maybe the lining of the gut, that would prevent that spike leakage into blood. And the thought then is that the patient will get less symptoms and less sick. It takes a burden off of them, and maybe their immune system kind of comes back up and is able to kind of, get rid of that remaining virus in the gut. And they've actually seen that a little anecdotally, in a couple patients. I mean, definitely requires further study and trial, but that's their thinking with the lorazepam trial. Yeah.
And that's still enrolling, correct?
Yeah, it definitely is. And they're really trying to recruit. Yes, please share it. Yeah.
Yeah, we'll share that link for everybody if you're interested in enrolling. Actually, someone just dropped it in the chat.
That's great.
The Dr. Younger study. Yeah.
Perfect. Thank you.
And
I do think that the monoclonal antibody study is in children, or at least pediatrics as well. I don't know if they're still recruiting, but I think they're at least looking to the under 18 population, which is great. UCSF.
It could be, yeah. It's cool.
That's exciting.
Yeah. So another example of a really, is something that we know is safe, that is a great safety profile, that is really exciting. And I'm glad that they're looking at least the under 18s. I don't know what the age range is, but
Yeah. I'm going to give Dawna, do you want to jump in and share what you would be interested in seeing in clinical trials? You're on mute.
I was just going to say, I'd love to see a link to the one that you just described. I think all of those would just, someone else just said, can you share a link? And I will say really good news about Yonkers team. They just got approval to be able to have you, because we wanted to get into that study, and they were like, kind of, you can hold on until we can see if we can, instead of having you fly out here and you might not qualify because you might not have the spiky protein in your blood, they've gotten approval to be able to have us send in our blood work to them as a screening tool. So I guess that would be the only thing, that as many of these studies as possible are able to have people remotely screen so that they're not having the extra burden, because, we all know how hard it is on the body to travel and to send our kids. And you talk about exposure, no one, getting on a plane in the fall, no one wants to do that. So yeah.
Right. I do want to mention, so Long COVID Families has a program we call Research Connect, where, if you're recruiting for a study, you can give us the information and the parameters of the study, and we will send it out to our mailing list. And if you're a family that's interested in participating in clinical trials, you can sign up on a form, and anytime we have something, you will automatically be emailed. So we'll follow up and include a link with that, because we're just trying to expedite it as much as we can to help. Next question. What should parents do if they think their child has long COVID? Dawna, what would you say?
If you think your child has long COVID, I think that the medical advice that's been given around looking for a test, because there's no test for it, figuring out what those symptoms are looking like in your kid, because POTS, it's not difficult to even, they have at home, you can begin to screen before you even get in to see a specialist for something like POTS, which seems really common. I don't know if anyone knows how prevalent it is among pediatric long COVID, but it seems pretty relevant.
We don't have a number for that, but I think I've seen numbers in adults that it's somewhere in the 80 percentile.
Yeah. So, I mean, if we look for what are the most common illnesses that we can test for, test your kid for that, because, and I should say more broadly, dysautonomia, because you don't have to have POTS to also benefit from that. I hear someone says that some doctors don't believe in POTS. I don't even understand people. But that, I think that would be really helpful, because I read it, POTS and MCAS, and I didn't know. I didn't know. And I wish, like in January, as soon as I saw it, I started looking at and having specialists test for all these different things. And some of them, like you said, they're low level, like a pediatrician can help you treat MCAS. I mean, it's over the counter, like you can begin with over the counter medicine for that. It's like not some major risk. What was the name of the first clinical trial that you said you would like before the low dose naltrexone and IVIG?
Mestinon.
Okay, could you put that in? Because I didn't catch that. Yeah, because these low risk things, that's what I would say.
So let me follow up with, so POTS, for anybody who's listening, that's postural orthostatic tachycardia syndrome. So that's when you experience a rapid increase in heartbeat when your body changes position, specifically when you stand up. There is something called the Nassau Lean Test. You can just Google it. It's online. It will walk you through the directions of how to screen for POTS. And that's often something that parents will take to their pediatrician, is the results of that Nassau Lean Test. And so you're looking for a jump in heart rate of at least 40 in children. But yeah, it's really, really common. It's a dysfunction of the autonomic nervous system. And one of the unfortunate things is that in pediatrics, many doctors are not aware of it. And even if they are aware, we don't have many specialists. And one of the things we're going to need are more pediatric specialists. Megan, did you want to add something about like what should families and parents do?
The one thing I can say is, if you have a doctor who is skeptical or you feel like is treating you with disbelief, I would not advise persevering with that doctor. Find somebody else, do what you have to do to get out of their care. You can give them a paper and on it if you want to. The new JAMA publication is a good one and say, look, I think for the sake of your other patients, you need to educate yourself on this, but you need to find better care for yourself and your child. I stayed with some of my initial clinicians for far too long, thinking that, we were on this journey together and they were going to help me. And it led to really bad consequences for me, prescribing the wrong drugs, which had really, they should not have been prescribed, for anyone with, this complicated history that I had after COVID, including like findings that I had at a stroke. They just didn't take me seriously at all. So don't persevere with a bad doctor. Do what you have to do to try to get into different practices. There are good doctors out there. It took me a long time to find them, but one reason is because I was trying to convince these doctors who just were not open-minded, and I have a PhD, right? And they did not listen to me. I don't think they're going to listen to you, but there are good doctors out there. And they do unfortunately often have wait times. The other thing, Dawna had brought up is this long wait for specialists. And I have a new thing that I do, which is to call up and try to get appointments. If I'm referred, I try to get 3 different specialist appointments. That way, with, a specialist in the same field, because that way, if the first one is a disappointment, I'll have another one, I won't have to wait, 6 months, 9 months to get to the next one. I'll have another one in a couple of weeks or a month or two, and you can usually work your insurance so that you can do it as long as you haven't gone to, the specialist yet. So it's, it's just, a tip dealing with this, dealing with the specialist referrals, the long wait times, it's incredibly hard. And, for those of you who are caregivers, I have the condition myself. My son is fairly healthy. Those of you caregivers, I just want to say, it's heroic, the amount of work that you all are doing on behalf of your children and the advocacy work and trying to hold it together. So yeah, thank you for all of that. We see you.
Yeah. So Megan and Amy, what do you think the most promising idea in pediatric long COVID research is that is not currently being pursued?
I have, there is one that is just, it's not well known. It's something that we are trying to look at the Brain Inflammation Collaborative. And it's like we brought up, a lot of the manifestations of long COVID can be mental health problems. But the idea is that they don't respond to the typical treatments that mental health problems would respond to because they're caused by an infection and neuroinflammation. It has a different etiology. So you might see symptom relief then with something like IVIG or immune modulators or antivirals. And so we need better diagnostics and we need people to be asking, what was the onset of this condition? So that's one of the things that we're going to be trying to work on at Brain Inflammation Collaboratives to try to figure out, how do we diagnose these? Because Dawna told this story about, the physical manifestation, these GI problems and stuff. And that was more how my own long COVID manifested as well. And I think it's a little bit more clear when you have an infection associated and you have all these physical problems and some mental health or neurocognitive